Hello everyone, welcome to the SHW Cross Team Seminar. So I'm Johnny Stokes, I'm based up in the MRC unit on the 4th floor. I've just joined the committee this year, so nice to meet many of you. So yeah, we're going to have 3 presentations today. So Alex is going to kick us off, then we've got Jenny, and we've got an online one, which is Hannah Scobie as well, who's going to join us online. So we'll start with Alex, and I'll just ask each speaker, you've got 12 minutes presentation, roughly. I'll give you a signal with a couple minutes to go. And then, yeah, we'll have 5 minutes roughly for questions for each person. Mike Fleming is joining us online as well, who's going to monitor the online chat and any questions there. So if you have any, feel free to stick them in the chat there. So yeah, let's get going.
Great, thanks a lot. So hi everyone, I'm Alex Fradera. I work in the Doctorate of Clinical Psychology program, but this research is research I conducted as a trainee on that program. So this is my thesis major research project. So I'm aware you may not be able to see me, but hopefully you can hear me okay. So that should work. So, but just to kick off, or maybe I'll minimize this. Easier. So as part of my research, I conducted a systematic review, which is a bit of a good place to start with this project, because it suggests that people living with chronic pain tend to score worse on cognitive screens, such as the mini mental state exam or the Montreal cognitive assessment. So these are ways of assessing how people perform on a number of different areas of cognition, but basically to get an overall score, see how people are doing. And in these populations who are basically healthy apart from chronic pain, they will do worse on these measures. And just to give a sense, we looked at this in a various different ways, but the estimates of the effect size were reasonably large. They're about 0.76 across 62 different studies. So it gave us a sense that this was something that seemed reasonably real and apparent across different chronic pain populations. So why is this important? Well, these kinds of screens, such as the MMSE, are typically used to look for possible dementia. So to look for either deterioration in performance over time, so changing scores, but very often taking the score and comparing it to a cutoff to classify whether dementia is likely in that person. So they're very routinely used, very important in dementia services. And so there's a question there, which is, does that effect of pain on the screen score have some implications for accurately classifying dementia using this approach? So that's the question that we set out to answer. So we investigated this using a large-scale database, which I'll say a little bit about in a moment, where a prior study has used some of the cognitive information in that database to do some dementia prediction in a very different way from ours. I won't go into detail. It was a multivariable approach, and we're much more interested in just the prediction using cognitive information. And so there's a few steps to this. So first, we want to make sure our model has some ability to gauge future dementia. So in other words, it's measuring something useful. It's some scales that basically work. We can then ask whether dementia is affecting the model. That's what we want to see. But whether when pain is in the mix, it kind of wrecks those scales. So it's much less informative. That's one possibility. Another possibility is that the scales still work, but it's a bit like pain has put a finger on the scales, always pressing it down, so it's more likely to hit that cutoff, perhaps when it shouldn't be doing. So I've made a slide, I just made this morning to see if I can illustrate this in another way. If you think about the 2 problem options that I've mentioned there. So one way you could look at this, screen. Yeah, so one way you can look at is pain changing the relationship between the cognitive information and the dementia outcome. So one simplified way that, or is it adding a baseline? So one simplified way you could think about these is, if you think about slopes, if you're measuring 2 different variables, think about slopes. If the blue slope is the slope without pain, then when you add that painful experience or painful condition, that the slope changes. So those red slopes, it might become steeper, it might become shallower, or maybe even there's a weird mix of the 2, that pain has different effects. Sometimes when pain is too much, it just washes over and they can't perform at all. But when it's intermediate, it's not having the same effect. So it's kind of really messing with that relationship there. But another possibility is that the relationship is basically exactly the same, but it's just there's a bit more of an issue going on. So it's a parallel kind of slope, if you want to think about that metaphor, but it's just in a different position. So you could sum it up as, does it kind of mess with the slope, or does it mess with the intercept, if you think about those things. This is a metaphor because the data that I'm working with doesn't have continuous data. So you'll never see, unfortunately, these slides again, because we're dealing with binary outcomes, dementia or not dementia. So it's a bit of a kind of conceptual way of looking at it, but I found it helpful just to think about what we're talking about in the rest of the presentation. Okay, so in terms of methods, we use UK Biobank, which is a very large-scale database with over 500,000 participants. Critical to us, people visit the assessment centre to collect the database many times, or at least in most cases multiply over different years, and sometimes assessments are taken one time or another time. And that was really important to us to get our head around to make sure that we were collecting useful data that could be meaningful. So in figuring out what sample we were going to use, so firstly we screened out anything that wasn't relevant, exclusion criteria like non-dementia neurological conditions. And then we wanted to create these clusters of cases with controls, so one case to 3 controls, using a matching process. So we began by identifying the cases that were of interest to us. So these were people who had a diagnosis of dementia after a UK biobank visit, but within 4 years of a visit where cognitive data was taken, because we decided for various reasons, too much longer and it wasn't going to be meaningful, but too much shorter and there's going to be too few people to work with. So we had that kind of window of cognitive information taken and then a diagnosis at some point within that window. And then those individuals we wanted to match, so we found some candidate controls who never had dementia, as far as we could tell from the data, were matched for sex and education level, were present at the same visit, were at a similar age at the same visit, had the relevant assessments completed and had survived a certain time following the visit to make sure that we were kind of comparing like with like. And then use a matching algorithm to match these up. And we ended up with 224 cases and 672 match controls. And we looked at cognition. We had 4 measures, and I won't go into those, but I'm happy to talk about those afterwards. But the key thing is that we took those scores, and after review and relevant transformations, we combined them into a single score, much like the cognitive screening tests, which normally use one score against one threshold using principal components analysis. And then the other measure, which you might be interested in talking about at some point, was pain. So we looked at self-reported pain lasting through 3 or more months in 1 or more areas of the body. So what we found is using a conditional logistic regression approach, using the design I've described and a few other details which I've added there, we found firstly that cognitive score did predict dementia outcomes. So this is what this is showing. It's a odds ratio for the overall sample and for the various subsamples, that with the exception of the smallest cluster where the data just wasn't really there to demonstrate that, we found that there was a odds ratio that the confidence interval didn't include 0, which means that the higher your cognitive score, the lower your odds of having a dementia diagnosis are in the period following. So the more likely it would be that you would be one of the controls and not one of the cases in that situation. So that's kind of the preliminary, that it kind of works as a imaging approach. But then the next step was to say, well, does adding pain change this? So is pain having some effect on that relationship? And that you can really see by an interaction effect. So we added, thinking about the overall group, so it's the same first term with a significant odds ratio. We added pain in. We didn't expect that to have a main effect, and it didn't. But we were curious, would there be an interaction between pain and cognitive score? And there wasn't. There was no indication of that. And we repeated that for all subgroup sub-analysis, and we didn't find any suggestion of that. So you could say then that idea that we've broken the scales once we add pain doesn't seem to be the case. The more pain, the less, the more cognitive performance rises, the less likely dementia is, and that's true regardless of whether pain is in the mix or not. But then we want to ask that other question about putting the finger on the scale, basically, whether pain is still pushing things down, even if the relationship is the same. And for that, it's useful to think about this idea of a matrix of possibilities that when we're looking at classifying people, there are 4 different possible outcomes. So we may incorrectly reject the idea that they have dementia, so it's that black box, so classifying them as healthy when we shouldn't. We may correctly reject dementia, so blue box at the bottom left, when they are in fact a control and they should be classified as a control. Or they could be correctly accepted in the top right, or in the bottom right, there may be a false positive where they're classified as ill having dementia when they don't. And that's really, that bottom row is what we're really interested in. So do controls end up getting falsely classified as having dementia just because they have pain? So is there a higher frequency there? So step one is to find a best cutoff that sorts people into these boxes. So we use the receiver operating characteristic approach, maximizing a statistic called UDEM, which basically means we're trying to balance sensitivity and specificity. So it's a kind of averaging out, you might say, of not favoring anything too much, but trying to work as well as we can with the data. It's not a brilliant model if you look at the confidence intervals, they're quite wide, but we know that there's some information in this model, so it's enough for us to explore a little bit further. And here, we don't have a case control system in place anymore because we're just looking at the controls now, pain and no pain. So they were never matched in any clever way. We were matching, so we've had to change our approach and use a different regression approach. So we're using ordinary least squares here. So what we found is that for the main analysis, chronic pain after controlling for everything else, its odds ratio just includes 1. In other words, it's just failed to reach significance if you want to look at it that way, that therefore we can't make any strong claim, really any claim that chronic pain is increasing that risk of being falsely classified as having dementia. But we did have some planned sub-analyses that we wanted to do, and one of them was about age. One reason is that the systematic review, older participants have much smaller impact of age, and younger participants have the larger. So we thought we'd look at some age analyses. And when we looked at a younger group, not much younger because Biobank is quite an old group, but those younger than 65 at the visit, we did find that chronic pain was significant. So one way to visualize that, I think this is helpful, is looking at the controls on the top row and the pain controls on the top row and the pain-free controls on the bottom row. We can see the red markings of those who would be classified as having dementia using the cutoff that we found. And you can see there's quite a few more. I'm going to come over the screen. I made it on that. Yeah, you can see that there's kind of a cluster, more kind of greater density of these red kind of just beyond the cutoff point here for those pain controls, and that's kind of leading to that difference. But we were curious if we calculated the cutoffs differently and we just use that young data, would that make any difference? So we did that. We produced a new cut point, so that's a different line here. It's a young only to the right of that. That's the optimal cut point there. And we found when that was in place, actually there wasn't any difference between the two different groups. So when we used basically normative data, you could look at it that way, just for the young group, then we didn't find this disproportionate result of false positives of false dementia classification for controls in that case. Okay. So there's a question mark there whether pain kind of tips the scales in the overall group. Not quite because of the Y confidence interval within this younger group, perhaps, but I would still be quite tentative in making any strong conclusions there. So it may put a finger on the scale, but it certainly doesn't wreck the scale. It's still an informative instrument, even with pain in the mix. There's some things I won't go into in detail here, but if people have questions, I'm very happy. So one thing is that the pain differences overall were fairly small in our sample compared to the effects that we found in the effects that we found in the meta-analysis, the systematic review. So there's some questions whether possibly that is that age effect I mentioned, that we've got a lot of older people here, and older people in the systematic review had the smallest effects. There may be a cohort effect, so how severe was pain in this group? These are volunteers who choose to go to UK Biobank. Do they have other fewer instances of other health conditions or other factors that may be at play in typical people with chronic pain? And there is a possibility we might have a better estimator. I won't say that now, but if people are curious, we can talk about that. And we have a few other limitations, including the reliability of dementia diagnosis and the lack of a formal screen. So our takeaways, I guess, would be to pay attention for clinicians where chronic pain is just around a threshold, and to use appropriate reference groups where possible, because that might make things more accurate. And a bit of a further exploration would be useful with the screening measures actually using clinical practice and not this model that we use using available data. And that we generalize from the previous larger, more complex model to find some validity just using this kind of pure cognitive model. Okay, thank you very much.
Do we have any questions then? 5 minutes or so.
Hiya. Yeah, so I've done a few kind of studies in UK Biobank, including a wee bit of chronic pain, but it was in the context of COVID, so I'm like not an expert at all. As well as what you've said about obviously UK Biobanks are generally quite a healthy cohort and they're a bit older, so you've got this affecting younger people, which is quite difficult to measure properly in UK Biobank. Did you say that chronic pain, it was defined as like 3 months of pain? Is that right?
Yeah, so yeah.
So I just wondered, like, especially in younger people, if pain had been going on for much longer, as well as the severity, if you look at the duration, you might see greater effects there.
Yeah, that's a really good question. And I think it's one of the things that we chewed on the most with this study. So we used, I think it's Alan et al, another study. Actually, I think on loneliness, but they used pain data, and they used the same approach that we did, which is to use the pain data that's available across the whole data set, which is based upon, are you currently experiencing pain and then a number of body areas, and then has this pain lasted for 3 months or more? And so we basically used that. I did explore another approach, which was to try and draw on chronic pain condition data. So there's a lot of ICD diagnosis information in there, and trying to pull that together using a reference of what would constitute chronic pain conditions. It turned out to be quite tricky to chew off in that particular kind of timescale that we had. And there were some questions there about chronic pain conditions that are really chronic and enduring, and ones that can arise, be chronic, but then disappear. And it's hard to know from the ICD information who fits in what category. So I eventually abandoned that, but that's one of the things I'm curious to chew on, is whether there is more in there that we can look at the pain, because it's quite a coarse measure. And I wonder whether, it's just not quite reflective of the realities of people that we might see, for example, in clinics, pain clinics, or indeed in older adult or memory clinic services who may have pain to a different degree that we're seeing here. There is one more source of data that we could be looking at, which is that there's a much more fine-grained pain questionnaire that was asked at one of the visits. The only thing is that that's one of the later visits, so the data quantity kind of drops massively because of that. But I still wonder whether there might be some way to see whether we could get back to that, even do some kind of mini analysis, just with a very clear, simple question that we might have enough power to answer usefully. Because I think that is a limitation, is what we're seeing in terms of pain.
I mean, I use the same measure. It's just, it'd be interesting to see, what more you could do with this, because it seems like it's something that would have an effect,
Yeah, definitely.
Seems intuitive. Yeah. It's interesting.
Thank you. Perfect. Mike, do we have any online questions at the moment?
We don't have anything, though.
Any other in the room?
I have a question. Thanks.
Yeah, please.
Yeah, thanks very much. That was interesting. I wonder, it's kind of a technical question. You mentioned that the sort of the covariates were baked in because of your case control design. I'm aware that sometimes you can sort of break the matching and add covariates, even though it's part of the design. I wondered if you've got any reflection on that.
As in adding additional covariates that might be of interest to you. That is an interesting question. I guess it's one thing that we wondered about, because there's an awful lot of things beyond pain that might be relevant to cognitive performance. And we did go back and forth on things like maybe introducing measures of mood. I can't remember if there's good sleep data or not, but I think there may be some data. I'm not sure. But one of the reasons we decided to stop at that is we realized that there was a danger that we'd be controlling out factors of interest that we would expect to be seeing and possibly naturally kind of clustering together with pain. So especially those two I've noted, sleep, depression, pain, there's some evidence that they kind of cluster together quite an interlocked way, and they're trying to pull them apart. We started to ask what we're actually asking there, because I think from my point of view, what is interesting is people who present at a memory clinic reporting chronic pain, and maybe with other things kind of sitting in the background, what might we want to be aware of, and that controlling those kinds of things out might be giving us kind of a pure answer about something else, but not necessarily kind of matching reality for those patients. So,
thank you.
Thank you.
Just like to thank Alex one more time.
Share the screen.
Yeah. Should be. Give it a go there. Jenny, I think I've made you co-host.
One minute. Yeah, had various different challenges today.
Where did this?
Right. So yeah, so we're going to use Mentimeter. So if you want to join in, I've got an interactive question at the end. So if you go to menti.com and you enter the code, I'll give you the presentation and the question. So you can do that on your phone. Give you a little minute on your laptop. Great. Okay, so I may have met some of you before. I am Jenny Crowe. I am the MBLS Digital Education Manager. I'm also a part-time PhD student in the School of Biodiversity, One Health and Veterinary Medicine. And I'm doing part-time PhD, particularly looking into what it's like to be an online student, particularly in the area of belonging. So I'm going to share today a bit about some interviews I did last summer. So it's great to be with you today. Okay, here we go. Okay, so why belonging? So when I first started out doing my PhD, I did quite a lot of reading, as per normal, and I came across belonging, and what I want to do as part of my PhD is really make a difference to the online students and their student experience. And belonging seemed to be a really interesting concept that seems to relate to retention and progression. And online students are quite different to on-campus students because it's not their full commitment. What they're doing, they're often juggling home life, work life. And also what's really interesting about belonging is it's quite subjective. It's quite a bit individualised. So students can start with different levels of belonging. Things like gender, ethnicity, whether they have a registered disability, income level, education level, all really impact their levels of belonging. So I really wanted to understand that a bit more and hopefully impact the student experience. Okay, so a bit about my research methods. So last summer I did 28 online interviews with students from across MBLS. So 36% of those were the School of Health and Wellbeing, because you have quite a number of different online programmes. And I'm doing phenomenography, which is very difficult to say. So what that means is that for those that are not familiar with it, it impacts the interview process, but also data analysis. So within the interviews, what you do is you have semi-structured interviews with probing questions to really understand the experience from the student point of view. Then in the data analysis, it's a bit different to a thematic analysis in that you put all the data together into one pool and then try and pull out differences between what the students said to share about the experiences and similarities. So I'm going to share some comments with you that kind of describe the experience from the student point of view and what makes a difference. So we've got these are some of the comments about things that staff do that make a difference and have an impact on the student experience. So I thought I'd give you a bit of time to read that. Hopefully, John, you can say as well. So some really interesting things there. I think what's interesting is that when staff go to teach in an online program, often they're like, oh, here's my content, is my role done then? And actually, I would say definitely not. Actually, what you do as staff members is actually really vital to the student experience and really makes a difference to the students. And they really want to get to know you. They really want to get to know what you're interested in, what's your research. Yeah, so that is super important to them. So communication was something that was brought up a lot by the students. That seemed to be something that really makes a big difference when staff get back to them, because they don't have that option to come to campus and knock on your door. They don't have the option to meet their peers so much. So yeah, and I think it is challenging when, oh sorry, my team's just got it sometime. It is challenging when there's, say, like a course and there's 10 people teaching on it. Okay, so it's how do we do this and how do we do this well? Okay. So next is a little bit about how students chat to one another, how their interactions are with their peers. So I'll give you a little moment to read that. I know we've got some people on board like Jim and Julie on the Zoom who are teaching a number of our different online programs, and Eleanor I see as well. And I think the top comment, we often experience this on the online programs, and whether there's something we can do about that or whether it's just the nature of online programs and that students get busy, they're focused on their assessment, they're often really targeted in what they do. I think another thing that's really interesting is that a number of the students fed back how they wanted to be part of extracurricular events, whether it's optional seminars, whether it's clubs and societies. One said they wanted to do an online book group. And it's how we facilitate that. And I know there's various people like sports staff that do invite the students to additional activities, and they are the ones that are available. Not all have the time, but they are looking to be part of the wider university. So group work was one thing that really seemed to make a big difference. I know group work is a bit of a pain for those that do teaching, but it does seem to really help them meet their peers and organise them. So it seems to be one thing that really makes a big difference. The next comment's about WhatsApp groups. We have some challenges with WhatsApp, and from a university point of view is that we don't have a data sharing agreement with WhatsApp. So whether we can do some of the things with Teams, but I know it's a platform that a lot of the students are on, and it does seem to be one that they're all using. Also, there's quite a few comments about time zones. All the online students are based around the world, so it can be pretty challenging if the live session is at 2 AM your time, and how to like factor that into what we do. And also like some are on clinical rotas, so it's often difficult to get them all into a live session. One of the questions that ask students about what they do to help their own belonging, and it may be that they're a bit of a self-selecting group. They are the ones that maybe participate more than others, but a number of them mentioned that they do make an effort to participate. But then another one said that when it gets too busy, they disconnect. When they're too busy with work and things like that, they tend to disconnect. Also, a number of them feel a little bit nervous about starting an online course and posting their comments on the forum. So it's what we can do to encourage them and help them feel more comfortable. Okay. Finally, I thought I'd share some aspects of the online experience for you to have a look. Wasn't working on the computer in the room. So I think the online programs really bring some opportunities to the university. These are not particularly students that would be on campus students because they have their home lives, they have their work lives, they can't always leave that behind to be an on-campus student. But that does bring some challenges when they're juggling lots of different things in their lives. But they are looking for ways to connect with others. So live sessions seem to be something that they are really keen and really helps build community in the online programs, if the students can make them. And there was a number of comments about some content being a little bit older in the online programs from a number of students. So they are watching. They are looking at what we are doing. Okay, so for the next steps, I'm in the middle of data analysis. I've also started up doing these virtual coffee sessions with the students that are doing their dissertation and project phase. And because what they fed back in the interviews was that they feel more alone in that stage because they don't have so many connection points. So I've invited all the students across NVLS from the online programs to join in with these virtual coffee sessions. So I've been doing 2 per semester at the moment. So we did one in September, we're going to do one in November, and also at different time zones, one at about midday and then one in the evening. So hopefully they will be able to join in with that. And then I'm kind of going into writing up for my PhD. And then some further reading if you want to go along. And yeah, it should be over. So your opportunity to have a little think about how you encourage belonging with your students. Okay, communication, yeah. Great, yeah. Yeah, the students fed back that they, as you've seen, they really like the little introduction videos that some of, I know Jim has done quite a lot of those, and because I used to work on see some of that work before, yeah. Great. So, oh, got some more. Yeah, icebreakers, very good idea. Yeah, the master students, they all come from really different backgrounds, so it's actually really interesting to hear what it's like from their work experience in their country, because we've got this global audience for the online program, so it's really interesting to hear about it, what it's like from their point of view, and really encourage those chats. So that's what I was going to share, so I'm very happy to take any questions, or if anyone wants to ask any questions in the future, feel free to send an email. Here is my contact details.
Thanks a lot, Jenny. Yeah, do we have any questions in the room?
Yeah, it's me again.
Yeah.
Have you written blogs about this?
So
I feel like I've read some of your, I've just done my PG CAT and like I wrote about belonging for online and international students. It might have been a different person, but I am interested in this. Obviously you haven't done your coffees yet, your virtual coffees.
So yes, I've done some last year, and then we did some in September.
And did people, because I emailed my online academic advisees like yesterday, and I feel really bad now, decided to not arrange a drop-in because they're like working and they're in different times, and I thought it's difficult to get time, right? So I just said they could contact me if they wanted to speak to me. But yeah, I just wondered what attendance was like, because there's so many factors, there's the working and the time zone and I thought, when did you even decide to do it?
So you can send out a poll and ask them when they're free.
Yeah.
And then I don't think you would maybe get all of them, but you might get a good majority and then find a time that can be suitable for them. I find that sometimes at lunchtime is good, or kind of early evening, like 5 o'clock. It depends where they are in the world. But I think asking them is probably the best plan rather than just picking a time.
I was a bit concerned about excluding people. Do you know what I mean? Like if I do one time and then some people can't can't make it, then that feels like they're left out. But yeah, I'll maybe do a poll then, because it does, I feel like I've not made an effort.
It's okay. I think it does give them that chance to ask questions and then follow-up questions. Also, if English is not your first language, then it's great because they can use the microphone to ask the question rather than typing it. I think record the session is a great plan for those that can't make it. Also, you could say to them if you've got any questions that you'd like that they like covered in the session. I think you don't get everybody, although I know that I see Anne McDonald's online, she gets like all her PBS students are very good at attending live sessions. So yes, I know that she's like, is everybody here? And most people are. So yeah, so it's nice to see, but I think they do appreciate it. But I think it's harder when the numbers get smaller, because then you're less likely to get. So if you've got a bigger cohort, then the higher numbers you get. But I think polling them means that you have a bit more of a knowing of whether any of them are free. Because I think it's a bit annoying if you organise a session and one student turns up and you're like, oh, was this worth my time? So it's not so easy, but yeah. Yeah.
Got an online question there. Eleanor, do you want to ask?
Hi, thanks, Jenny. It's Eleanor. I'm sure we've probably asked you this before, but just what's your stance on putting a grade or a mark on the discussion forum contributions, like 5 or 10%? It's just I've had feedback from students that wanted to see that, students that were notably, contributing and felt that others weren't, and they felt that this would be a good way to encourage it. I've sort of always been a bit against it, but yeah, it's I don't know, I just wondered if you had a stance on that or not.
I think it's an interesting one. I think it does encourage participation. I think maybe if it's done too much, it can not be so good. I think it depends. What that facilitates is them writing one post. It doesn't facilitate them asking a question to another person, which kind of is maybe what builds the community and builds the discussion. I think some students are targeted and they're like, I will lose 10% if I don't have this time. It's kind of, there are some that 10% is not enough, but there are some that are motivated by that. So I don't know if it's a one size fits all.
Got another minute if anyone else has another question. Otherwise, thank Jenny one more time. Thank you. Right, I think Hannah, are you able to share screen? I think I've made you co-host.
Yeah, I think so. Let me just can you see that okay?
Yeah, that's good on this one, thank you.
Perfect, thanks. Okay, I guess I'll just get started. So I'm Hannah Scobie. I'm a researcher based in general practice and primary care. Today I'm going to talk you through some of the work I did for my PhD. My research focused on understanding lung cancer screening participation, and I have a particular interest in how we invite people to take part in cancer screening and how that might impact uptake in those from more deprived groups. So I thought I'd give a wee bit of context first. So lung cancer is the leading cause of cancer death worldwide, with Scotland having one of the highest rates of lung cancer in Europe. Those from more deprived backgrounds are disproportionately more likely to be diagnosed with lung cancer and also more likely to die. So these figures here are from Scotland's recent cancer strategy, and I think they really indicate the scale of the problem and really highlight the health inequalities that people in Scotland really experience. So those living in the most deprived areas in Scotland are 3 times more likely to develop lung cancer, and cancer-related deaths are 74% higher in the most deprived populations compared to the least deprived. So I think it really highlights what the issue is and why it is important. So we know that lung cancer screening does offer the potential to detect cancer early, meaning it's more treatable. Currently in the UK, there is no national lung cancer screening programme. However, with the recent success of a US-based lung screening programme, the UK Screening Committee have now recommended lung screening in the UK. So the hope would be to target those at highest risk of lung cancer. And we know that those in more deprived backgrounds are at higher risk of developing lung cancer and dying from lung cancer. But unfortunately, the people in those groups are also, the uptake is 20% poorer in other cancer screenings. So we need to think about a way in which to encourage uptake in the highest risk groups. So one way, like I mentioned, I'm really interested in how we invite people to participate in screening, and one way is to explore different ways to invite people and if that impacts uptake. So as part of my PhD, I worked alongside the ECHOS trial, which is Scotland's first lung cancer screening trial. And that aimed to test a new cancer screening test, which was a blood test, so slightly different from the conventional CT X-ray screening. And that screened 12,000 people at high risk of lung cancer in deprived areas of Glasgow, Tayside and Lanarkshire. And by high risk, the trial defined that as age between 50 and 75, a smoking history, a family history, and living in an area of high deprivation based on SIMD. So my role in this was to do some analysis on the baseline questionnaire. So all trial participants were required to complete the baseline questionnaire before being randomised into the trial. It's quite a comprehensive questionnaire, including things like demographics. I've not gone into too much detail about what measures they used, but I can give details if that's somebody's interested. So yeah, measures included demographics, smoking behaviour, health state, health anxiety, lung cancer illness perception, and also this recruitment method, which is obviously what I'm focusing on today. So the trial had two different types of recruitment. So it had GP-based recruitment and community-based recruitment. So the reasoning behind having two was that pre-trial focus groups indicated that those at high risk and living in more deprived areas would be less likely to engage with a letter from their GP, but the focus groups sort of indicated that maybe community-based recruitment would be best for these groups. So the result was that the trial included both types of recruitment. So by GP recruitment, we mean those who are identified by their as eligible for the trial via their GP records, and a GP endorsed letter sent directly to them to invite them to participate. And community-based recruitment is completely different. So that's a more passive recruitment method. So that included doing advertisements in high traffic areas such as shopping centres, hospitals. It included things like posters, banners, stalls, and also local media campaigns, including radio adverts. So if a person was interested in taking part in the trial, they would have to contact the trial coordinators directly and to ensure eligibility. So in a sense, it was kind of a self-select option of recruitment. So there was two main aims of my analysis, and that was to understand what the most effective way to engage and invite those at highest risk of lung cancer to attend lung cancer screening, and secondly, to understand if there's any psychosocial differences across the recruitment types of the lung cancer screening trial participants. So we can see here that there's quite an even balance between males and females in the trial, and over half the participants were aged between 50 and 60. So in terms of recruitment type, those from the most deprived backgrounds are more likely to engage with a personalised letter from their GP compared to engaging with community advertisement. So this was completely contradictory to the findings of the pre-trial focus groups, which indicated that they believed that people from more deprived backgrounds would be more willing to engage with community advertisement. In terms of the psychosocial measures, illness perception, those recruited through their GP were more likely to have poorer perceived personal control over developing lung cancer. They're more likely to not know how likely it is to get lung cancer, and they're more likely to not know if a blood test can detect lung cancer. Also, interestingly, those recruited via the community were also less likely to have smoked in the past 7 days. So the results indicate that beliefs about lung cancer and lung cancer screening do vary by recruitment type, and that community and opportunistic screening invitations encourage uptake in people from less deprived background. So essentially, those recruited via the community were healthier, more affluent, and had a greater understanding of their own risk of lung cancer, and were also less likely to have smoked in the past week. Personalised GP endorsed letters are more effective to reach high risk people high risk of lung cancer and living in more deprived areas. So these findings are they're completely in line with the current literature in other types of cancer screening, such as colorectal cancer. And some of the mechanisms behind the use of GP endorsed letters include people trusting the recommendation of their healthcare provider. And that might be one of those reasons why people are more likely to engage if it's a personalised letter from their GP. So just a quick summary here. So community-based recruitment to screening trials attracts higher uptake from more affluent groups. Community-based recruitment may further widen cancer screening inequality unless we use a range of different recruitment methods. And also a recommendation would be to provide further effort to enhancing GP-based recruitment, while also remaining mindful of the sustainability on primary care. I think I have some references there. Yeah, that's me, if anybody has any questions.
Thanks a lot, Anna.
Let me just stop sharing.
So shall we try online first and switch up since it's an online presentation? Does anyone have any questions online? Is that hands? Okay.
Let's see any
Is that-
any comments? There's nothing in the chat, and there's no hands up online so far.
Okay, no problem. And in the room top.
I could ask one.
Yeah.
Just because I could be wrong, right? With the community adverts for participants, does that mean that if you're only interested in people who are in more socioeconomically deprived areas, does that mean that people are volunteering, but then quite a high proportion are rejected because they're not eligible?
So they would still be eligible as long as they fell within that postcode. So it would be based on postcode on their SIMD. So yeah, I guess I'm not sure if I know the answer about the number of people who were then not submitted into the trial.
Yeah, because it just struck me that that's something that people wouldn't, I mean, I don't know what it said on the advert, if it was looking for people from certain areas and how that would even be expressed, how that would be communicated, but it's something that lots of people wouldn't know,
Yeah.
like what is IMD area. And
Yeah,
I'm interested because the study we did recently, it was a different method of recruitment for our long COVID study. We sent text messages to people. It was based on their PCR results, and you had to have had a positive COVID PCR test to be eligible. But I managed the study inbox, the emails, and had quite a lot of communication from people who were desperate to take part but
Okay.
couldn't. And it's just quite a difficult thing to deal with, I thought, with people who really, really were keen to participate and you couldn't. So I just thought this method, you might get quite a lot of that, but you don't know, you might get quite a lot of people who are desperate to be involved, and it has to be explained to them the reason why they can't be, which is just interesting how you would do that.
I think with community advertisement, in other studies that they've kind of they sometimes come across the kind of worried well phenomenon. So people are kind of not screening to detect cancer, but screening to reassure themselves that they don't have cancer. So it's not quite the group of people that we'd be looking to increase uptake in, because I don't think those people are the issue in the first place. Yeah,
I just thought you'd get quite a lot of that. People who are like, oh, that's a good idea. Okay, that's great. Yeah.
Any other questions?
I just thought it's kind of what I expected.
Yeah, and on that, Hannah, did you take it back to, was it the PPI panel that suggested to begin with that the community kind of approach would be the one? Did you take it back to them after and kind of talk through?
Well, no, so it was based on, so there's pre-trial focus groups with so that were run through, I think, University of Nottingham. So they did the focus groups for that before the trial even went underway, and it was with people at high risk of lung cancer and living in deprived areas. So I don't think it was a specific PPI group, but yeah, I would be obviously happy to share any findings with them.
Did they have any reasoning in the focus group that, like, mechanisms, because you talked at the end about the mechanisms?
Yeah, so some of the in that kind of the study with the focus groups was that people thought that they got too much post and too many letters from their GP, so potentially they would just chuck it, and they might be more likely just to be interested in if they've seen a poster. Some people also thought they might be offended if they received an invitation, because it made them feel like they were to blame. So if they were a smoker, they might feel like they're to blame for any potential sort of health issues that kind of result in that. So people thought it in some ways is quite patronising to receive a sort of unsolicited letters asking you to take part. So yeah, there was sorts of lots of different kind of reasoning behind it. Yeah.
Do you have any final questions for Hannah? Yeah, go ahead.
How well can you control for your way of recruiting?
So we couldn't.
Does it matter in a way? Because if you obviously maybe it does, but if you measure the characteristics of people, then maybe it doesn't matter how you recruit them.
So that was one of the kind of issues. It wasn't, the type of recruitment wasn't controlled for. So there could be some sort of contamination of recruitment types. So somebody invited via their GP could also have been seen posters or, that sort of thing. So I think that the ideal would be to use different recruitment types in different areas. But obviously that wasn't the sort of main aim of the screening trial, so it was just a kind of sub-study. But yeah, kind of going forward, testing that kind of theory would be quite interesting.
Thanks a lot. Let's thank Hannah one more time.
Thank you.
Yeah, thank all our speakers, 3 great talks. Thanks everyone for coming along online and in person. So I think that's the last one before Christmas, believe it or not. So it's coming quickly. So we're back in February, I think. So watch out for the emails around then. Yeah, and thanks very much.
Thank you.